Well, hello, everybody, and welcome to Surgeon's Log 2020, our third episode. Welcome in particular to all our friends from across the world. I know there are viewers all the way in England, in Europe, in Asia, and even in Japan. It's very early in the United States, so I sure as hell don't think that we're going to get a lot of US audience, but we're going to get hopefully a lot of international audience. The format of the webinar is very unusual. It is case-based and not lecture-based. So we're going to start usually with a trainee on hot seat, what we call, and we go through a case that is a complete unknown for him. And then we're going to work through the evaluation and choosing the approach. The reason why we want to do this is that strategy and strategizing in skull-based surgery is a process. And you only get that process if you can actually hear the thinking gears clicking. So we're hopeful that the trainee in the hot seat would be able to verbalize what the audience is thinking as we work through that case. Then we're going to hand over the webinar to the presenting surgeon, and then finally the discussant. I'm going to go share my screen now, and we're going to go into the talk. And so away we go. Let's introduce our panelists. Our distinguished guests today are Simon Cudlip and John Jane, renowned UK neurosurgeon and the skull-based expert from Oxford. And Dr. Jane, Professor Jane, of course, is the Crutchfield Professor of Neurosurgery and Professor of Pediatrics from the University of Virginia. And we also have on the hot seat a PG514 resident, Jeff Hakim from UVA as well, who's gracious enough to be on the hot seat and work through the mysterious case with us. So here we go, Puella Aeterna. So Jeff, you got a 17-year-old woman that comes to see you in the local emergency room and with the chief complaint of headache, nausea, vomiting, and altered vision. The headaches have been going on for quite a while now. But has been noticeably worse in the last 10 days, and is now associated with morning vomiting. The vision is blurry over the last several months, and all these are her symptoms. Even though she's alert and oriented, she's extremely pale, and her blood pressure is 85/60. So I'll pause a little bit there for you to think about it for a little second. The visual acuity is slightly reduced. She's only counting fingers. And it's very difficult to access her full visual field. She has some papilledema. And the rest of the exam is not quite remarkable. I'm going to give you some labs here now and the examination. She's younger than her stated age, and she tells you now that she stopped menstruating 3 years previous to seeing you. And she seems very lethargic and kind of sleepy in the ED. So the labs are as they show on the screen. Her sodium is 151 and her K 3.8 with a creatinine very high, and her serum and urine osms are there. She's on the verge of something kind of bad here. So what's going on? What are the most acute things that you see in the information?
Yeah, I mean, based on the patient's history, the headaches, visual changes, nausea, vomiting, lethargy, I'm concerned about hydrocephalus. I would want to, get a quite urgent CT head to take a look at the ventricles, make sure, she doesn't need an EVD emergently. The sodium being high and kind of some of the other aspects of the history with the, cease menses, younger than stated age, they kind of point to some sort of endocrine dysfunction as well. But probably would want to start with a CT head just due to the concern for acute hydrocephalus.
And I'm going to show you that in just 1 second. Now, the sodium being 151 and creatinine being super high. Mm-hmm. Any thoughts on that as to something you might want to intervene on before the scan's ready?
I mean, with the sodium so high and the creatinine very high as well, worried about that she could have some sort of kidney issue as well. acute kidney injury, and her low blood pressure as well. Yeah, it does make me worried about like a adrenal crisis that she may have. She may need some stress dose steroids as well.
Okay, so you think you're going to give that to her before, as you're waiting for the scan?
I would probably want to have the nurse draw some blood so that we could get a cortisol and ACTH, and then immediately give some steroids.
Okay, so the MRI is ready before the CT scan. So boom. I'm going to show you this one, and then I'm going to show you the next one as well. And I would stop there and ask you for your thoughts.
Sure. So this looks like a T1 weighted MRI, sagittal and coronal. Shows ventriculomegaly. It looks like there's a mass, suprasellar mass invading into the third ventricle as well, probably causing obstruction, foramen Monro and hydrocephalus, both lateral ventricles. Fourth ventricle looks okay.
And so does that give you more thoughts about the laboratory abnormalities as to what she's...
Yeah, so this would make me think that her laboratory abnormalities are likely due to, pituitary dysfunction, and that she needs stress dose steroids at this point.
All right, so and your thoughts about the mass itself?
Mm-hmm. So the mass itself, with a kind of heterogeneous, it looks like there's maybe a cystic area there as well. I think that's, yeah, this is actually maybe a flare MRI actually, but it looks like there's a cystic area kind of suprasellar invading into the third ventricle. Differential for this, worried about possible, probably craniopharyngioma would be first on my differential. You could also consider, a large pituitary adenoma. Could also have other things like dermoid. Could also be hamartoma.
But your number one thought would be?
Probably craniopharyngioma.
Okay, so you give her the stress dose steroids. You already did that. You sent off the labs completely appropriately, just like we designed you to do. You sure you haven't seen this case before? So here you go. First dose, the hydrocortisone goes in, and suddenly the urine picks up dramatically, and she dumps a large volume. And the prolactin, as you can see there, the IGF-1 you can see there, nothing jumps out at us except maybe the cortisol. It's a random cortisol, so you don't really know, whatnot. What about all this?
So with the large amount of dilute urine, as well as the low cortisol, again, worried about pituitary suppression, both anterior and probably posterior pituitary as well, possible DI as well. I think her, you had in the initial slide, something about the urine osmolality.
Being very low.
Very low. So yeah, all of that is consistent with diabetes insipidus, I think, with the high sodium as well.
So would you at this point give her something in addition?
I would probably consider giving her DDAVP in addition to the steroids.
All right, so back to these for 1 second, and then we're going to move on. Now, so can you list for the audience here, what are the active issues, some of which you already dealt with? What are the active issues here?
I think the hypopituitarism, the low cortisol, and then also the DI would be kind of the two pressing problems. Also the hydrocephalus from ventricular outflow obstruction at third ventricle. So therapeutic goals, I think, would be one, correction or cortisol replacement or corticosteroid replacement. I think dealing with the electrolyte abnormalities with the DI, with possible BDAVP. And then the third would be addressing the hydrocephalus and the lesion itself.
Okay, so let's go through that. What about the hydrocephalus?
Yeah, so for the hydrocephalus, given that you said she's lethargic and uh, does it seem like she's no longer, interacting and she's um, like she's unarousable, or is it that she's just, kind of sleepy? Or
Mr. Cudlip, can you answer that one?
In terms of her level of consciousness, I
Yeah.
think she was rousable, but she was obeying commands, but had her eyes closed, but was pretty sleepy even after she was given some hydrocortisone.
Okay.
Now, Jeff, let's put it this way. Everything's at your disposal. I mean, you're at UVA, so you're used to this, okay? So the world is your oyster. You have an MRI ready for you. You have all the resources ready for you. So you're not restricted because, someone's blocking you to do something. How would you handle the hydrocephalus?
Yeah, so, I am a bit worried about her level of consciousness, and, that I think ultimately this will need to go to the OR for, more definitive treatment. And, but I would like to have, that done after, having ENT involved, because I would probably, looking at the MRI, want to do planned something like a combined approach, endonasal for the, I think there was a cellar as well as supracellar component. And then probably for the third ventricular component, she would also need a cranial approach. Different options could be like a subfrontal versus interhemispheric.
Let's concentrate on the hydrocephalus first.
Oh,
so
sure.
with that, what are you going to do?
So with the hydrocephalus, though, I think I probably would place an EVD.
Okay. So place an EVD.
Mm-hmm.
Now you've got at least the acute component of the hydrocephalus solved.
Mm-hmm.
Now what is your approach for the big picture?
Yeah, so for the big picture, I mean, looking at it, I think a combined approach, like I was saying, would be best. Doing the endoscopic transsphenoidal approach would give us good access to the, low inferior portion of the tumor. We'd be able to directly access that part of the tumor, and, the advantages of, being able to see the underside of, the chiasm, make sure we can protect the perforators going to it. I think that'd be advantageous. For the part of the tumor that's invading into the third ventricle, I don't think that could be addressed solely with the transsphenoidal approach. I think we would want to do a cranial approach as well. And again, I think probably—
What type of cranial approach are you talking about?
I think interhemispheric transcallosal would probably be reasonable.
So an open approach, okay.
An open approach. You could also do a, transcortical endoscopic approch. I know Dr. Syed does those.
But what would you do?
I would probably do the interhemispheric transcortical.
Okay. What about timing? Together, separate? Which goes first?
I think I would probably do the cranial portion first. So the interhemispheric transcallosal approach.
Okay.
Debulk the tumor in the third ventricle, try to get his resection there. Because I guess my worry would be if I, go from transsphenoidal first and debulk things and, possibly have CSF leak, it may make the cranial approach more difficult.
Okay, so to summarize, you've corrected her endocrine abnormalities with the cortisol and DDAVP. You're going to do a EVD at the bedside to address the hydrocephalus. Then you're going to go interhemispheric for the top part and endonasal for the bottom part.
I think so.
That's your grand plan.
Mm-hmm.
Outstanding. I am now going to turn the podium to Mr. Cudlip, our guest from Oxford, and he'll tell us what he actually did.
Yeah, so our priority here was to resuscitate the patient. So she was clearly suffering with acute cortisol deficiency, adrenal crisis, based on her BP, the pathology that we could see on the MRI scan, and also her urine electrolytes pointed to diabetes insipidus. So the priority was to give her hydrocortisone acutely. And once you've got the hydrocortisone on board, you can start to worry about the other problems, because the danger is, of course, if you rush to take someone to the OR and treat their hydrocephalus and they're Andersonian, you'll end up in all sorts of trouble very early on, as soon as the patient is anesthetized. So I can't stress enough the importance of thinking about the non-surgical management of this patient before you consider surgery for all the residents. So correct the cortisol deficiency, correct the electrolyte imbalance. We're not a huge fan of giving DDAVP acutely in the UK. We tend to, if a patient's awake and alert, we tend to get them to drink to thirst and try and replace things physiologically, and then get a handle on whether DDAVP is going to be required in the longer term. I also have a rule that neurosurgeons are not allowed to prescribe DDAVP in my department.
Really?
I think it's dangerous. It's a dangerous drug if it's mismanaged. You can get huge swings in sodium where patients are suddenly treated with DDAVP, become hyponatremic, and then swing the other way. It can get out of control if you're not careful. So once the patient's resuscitated, then we need to treat the hydrocephalus. And there's many different ways of treating this. We'll get onto that in a minute. EVD is a perfectly safe and reasonable way of treating this, but you may need to place bilateral EVDs. You can see these cysts filling the third ventricle may obstruct both lateral ventricles, and so therefore we may need to consider whether bilateral EVDs is a safer option. I'm not a fan of bilateral EVDs. I think EVDs would be perfectly reasonable. We did something slightly different, but it depends on the timing. You know, if this is happening at 3 in the morning, you may have a different view on what is safest and easiest at that particular time. This was an out-of-hours procedure, but it wasn't antisocial. Then we need to look at the other endocrine deficiencies. She's panhypituitary. You need to get a formal visual assessment once she's a bit more awake and cooperative, and then plan to deal with the suprasellar lesion once we've solved those initial first 3 problems. So we talked about dealing with a hydrocephalus, so single versus bilateral EVD. You can put a shunt in. I mean, there's an argument for shunting the patient. Again, I would not do that, but a lot of these patients end up needing CSF diversion, and it would buy you time, certainly, and avoid the risks of an EVD such as infection. You could do an endoscopic septostomy and leave an EVD, avoiding the need for bilateral EVDs. So if you put the lateral ventricles in communication, it would allow you to put in a single EVD. You could also put in an EVD as part of your definitive craniotomy. So if you're planning on going straight to an open approach, you could decompress the ventricles as part of that procedure. Our actual chosen operation was an endoscopic cyst fenestration, biopsy of the cyst, collapsing the cyst, but also as part of that procedure, I prefer to do a septum pellucidotomy, just planning for the future in case the patient were to need CSF diversion, and it allows you to put in a unilateral shunt if necessary. So when we do these procedures, I tend to use the stealth electromagnetic navigation just to plan your entry and trajectory perfectly. You can see on that coronal T1 MRI that the left foramen of Monro is more obstructed than the right, so I chose a left-sided approach. And we did a standard burr hole, really, for an ETV-like approach with the burr hole just anterior to the coronal suture and about 4 centimeters mid-pupillary on the midline. So here's the endoscopic view, and I think this starts with the septostomy. So you can see this is a monopolar passed via the working channel of a ventricular endoscope. And we're just performing a septum pellucidotomy, opening the septum into the contralateral lateral ventricle. This isn't strictly necessary, but what it does, it creates a safety net so that if you require a permanent CSF diversion later on, or you're worried about the lateral ventricles being in communication, you've solved that issue. So here we have the classical view of the foramen of Monro on the right-hand side. You can see there the choroid plexus thalamostriate septal vein. And what we've done here is we've used an epidural catheter. So this is an off-license use of an epidural catheter down the working channel of the endoscope and punctured the cyst directly. And I like doing that because what it means is that you spill as little as possible of the contents of this cyst into the CSF space. And the reason for that is it's quite a reactive content, so it creates a chemical meningitis, and the patients can become quite unwell. So here we've created a wide opening in the cyst. We're biopsying the cyst wall, removing some of the lining. It's coating the inner lining of the third ventricle, you can see there, peeling off some of the cyst. And debulk this as much as you can. This is the bit of the tumor that's quite difficult to approach surgically via an open procedure. And so, as well as dealing with the hydrocephalus, we're trying to just debulk this portion of the craniopharyngioma as much as you can. You can see the typical appearance there of cranio with flecks of calcification in the cyst wall, the floor of the third ventricle. You can see calcification there anteriorly in front of the mammillary bodies. So stripping out as much as you can. There's a little bit of bleeding at one point, which is easily controlled with monopolar diathermy. These solid portions, we debulked a little bit, but the trouble is you don't really have control over any bleeding points in that region. So I think I was a little bit more conservative with those more solid portions of the tumor. So ultimately, hydrocephalus was treated. We left an EVD in because there's always a chemical meningitis after these, even if you try and collect as much of the fluid contents as possible. So this is the day following that procedure. You can see there's a nice decompression of the cystic portion of the tumor filling the third ventricle. And actually, it looks as if most of that has been removed. You've got a little bit of cyst wall lining the third ventricle on the left lateral wall there, but the ventricles are now in continuity. And the patient is now safe. So now you've got breathing room to plan the next step, which is to directly approach this probable craniopharyngioma. So here we go. We need to think about the risk-benefit strategy for dealing with these tumors. And I'm sure you all know, and amongst the panel, there'll be a wide view on how to approach these tumors. Many surgeons would choose an open craniotomy, so either a interhemispheric or transbasal approach or pterional. It's perfectly acceptable to do those procedures, whatever safely achieves a maximum resection with minimum morbidity. Now, for this particular abnormality, I think there's a few things we need to take into account. It's principally a midline lesion. It doesn't seem to extend very lateral. On the MR, you can see the long axis of the tumor pointing endonasally. The other thing is that the chiasm is prefixed. So yeah, Walter, there you go. So the chiasm is...
Actually, I'll point out right there.
Yeah, there's the chiasm prefix. And just above it is the ACOM complex. That may present a bit of a challenge if you're going to do an open procedure. And the difficulty with the craniotomy approaches is that essentially you end up working between the cranial nerves and vessels. So you end up working between the openings, either subchiasmatic or between the carotid and the optic nerve, or even behind the carotid and the oculomotor nerve. So all the time you're working between these important neurovascular structures, and you may well have to go through the lamina terminalis to get to this if you're going to do a craniotomy. Do you want to flick to the next slide on what? And one after, yeah, there we go. So these are all the different sort of options that you have at your disposal. You may just choose to do a cyst aspiration and irradiate the patient, which some centers would choose. I think that's probably historically now less commonly used because the evidence suggests that a maximum total resection followed by adjuvant radiotherapy is probably the optional treatment. You can do a pterional craniotomy with or without the zygoma and orbital bar. I do a lot of eyebrow craniotomies using a mini supraorbital with a pterional extension that you could do for this. You could come into hemispheric, transcallosal, transchoroidal, or transventricular. So I prefer the endonasal endoscopic approach, and for lots of reasons. I think this tumor lends itself nicely to that. So I've outlined the chiasm in yellow and the ACOM complex in red. And you can see the chiasm is prefixed. So that means an anterior or anterolateral craniotomy is going to be difficult because you're going to be working through a relatively narrow space between these neurovascular structures and have to probably through the lamina terminalis. The long axis of the tumor, as I say, lends itself to the endonasal approach. And there's a nice window between the lower margin of the chiasm and the upper border of the normal pituitary gland. So you've got a decent working channel there to get to the tumor and work safely underneath the chiasm and try and delineate the small perforating vessels supplying the chiasm and hypothalamus. I've outlined the stalk in blue on this. I think the stalk is involved in this tumor. And as you can see from the chemistry, preoperatively, the patient almost certainly has diabetes insipidus already. So therefore, we have to consider counseling the patient as to sacrificing the stalk in order to achieve a maximal safe resection. So if somebody had well-preserved pituitary function and no evidence of diabetes insipidus, I would do my best to try and preserve the stalk and the hypophyseal vessels supplying it. But here, I think, if you reach a stage during the surgery where the preservation of the stalk is going to limit your ability to achieve a maximum resection, in this particular case, we counsel the patient about taking the stalk.
I want to highlight one thing you said, Simon, and that is that a lot of endoscopic surgeons look at this interval very, very carefully and paying a lot of attention to it. As you point out, and I just want to highlight, this gap, which is variably called infrachiasmatic corridor or the infrachiasmatic interval, is critical in assessing whether an endoscopic endonasal approach is a good one, a bad one, or somewhere in between. So I just want to emphasize that for all the trainees, that is a very important thing to evaluate on your preoperative scan there. Should we go next slide? There you have it. There you have your
that distance. The other thing on the right slide, so you can see there's all different descriptions of how much bone you need to take with these procedures. So clearly you need to get adequate exposure to see what you need to see to access the tumor safely and preserve all the relevant neurovascular structures. But in this particular case, you can see that removing the planum sphenoidale is not really going to confer any advantage because of the position of the chiasm. So here you really need to extend your bony opening to the tuberculum and the limbus sphenoidale, but not necessarily remove any planum. And that's important because the planum is the place where any CSF leak occurs. So if you're considering your reconstruction at the end of this operation, if you can leave a bony bar at the back of the planum, it's easier to anchor any graft, any material you're going to use as an inlay, and also it avoids this problem with the nasoseptal flap lifting off anteriorly. So this is our setup. I tend to use navigation for these cases. I have an assistant. It's slightly unusual in that I see a lot of my North American colleagues operate with ENT. I actually do a lot of these cases on my own without ENT. I use ENT when it's a complicated case or where it's a child, where the access is difficult. But my fellow's standing on the right-hand side. He's got his own screen looking cross-court. I'm looking at my screen. We've prepared the abdomen for fat. I now tend to prepare the thigh, actually, because I quite like using fascia as well. I use lumbar drainage in these cases. There's a nice paper that came out of Pittsburgh, Paul Gardner and his colleagues, randomizing patients to lumbar drainage with extended approaches with clear benefit in terms of postoperative CSF leak. And we do the classical expanded approach with a binasal, four-handed approach, drilling out all of the septations in the sphenoid, getting a nasoseptal flap early on. And then it's essentially a micro dissection technique, so a bimanual microdissection technique using sharp dissection
And Simon, I want to give you a video. It's full run, so we should probably move on to that. You can describe the action for us.
So here you can see septations within the sphenoid. We've got the lateral OCR there on the left-hand side of the screen, expanded pituitary fossa. So we skipped on a little bit. It may be longer than you want this video, Walter, so feel free to...
I think we're okay.
So we're opening the pituitary fossa there. You can already see the chiasm. That's how prefixed it is. So if you look through the arachnoid superiorly, you can see the chiasm. You can see some calcification within the tumor. Pituitary gland is inferiorly. So I haven't extended my opening to the planum because it's not necessary. It's not going to add anything to this exposure. So there's the arachnoid over the tumor. You can see typical craniopharyngioma. It's rather indurated, calcified. So we're not going to be able to, and you can see the stalk inferiorly there going straight into the tumor. So this is going to be difficult to manipulate. So we need to try and debulk the tumor initially. So I try to dissect the plane as much as I can, but then we get limitation by the actual size and consistency of the tumor, which is pretty tough. So then we go on to debulking the tumor. And as you debulk the tumor, you can then start to develop the planes, both subchiasmatic and also laterally, and follow. There we go. So we're seeing along the side of the tumor now after it's been debulked. That's the third nerve. That's the P1 vessel. And there you see the PCOM arising and the PCOM perforators. And you try and stay in this extra-arachnoid plane, dissecting tumor capsule outside the arachnoid, which tends to be preserved. So linequist tends to be preserved, and you can exploit that to try and dissect tumor capsule from all of these vessels. And here we've entered the third ventricle. You can see the opposite P1 vessel there. And here we're in the third ventricle, sharply dissecting tumor from the undersurface of the chiasm and the hypothalamus. And you tend to reach a stage in these operations where it's difficult to know where hypothalamus starts and gliosis stops. So here I decided to stop because there seemed to be tumor invading hypothalamus directly. It could have been gliosis, but my feeling was it was probably safer on balance to minimize the morbidity of this procedure, achieve a maximal safe resection, decompress the chiasm, and achieve what we set out to achieve. So just to summarize, the approach was the expanded endonasal endoscopic approach. The modifiers for that were that I actually left the planum intact in this case because it didn't lend us any advantage in terms of exposure. And it would have actually put us at a disadvantage by just making a larger defect that needed to be repaired. So the position was a neutral supine position, bony opening, tubercular and cellar. And I tend to use an X-shaped dural opening.
And a spectacular result. How did she do clinically?
Yeah, very good, actually. So she was quite a fragile character. This is really unusual for the UK. Both of her parents were crack addicts, and they put her up for adoption. So she was living with foster parents, and then living in a child's home. So her vision improved pretty rapidly, actually. Her vision got better quickly. Obviously, her papilledema persisted for a little while, as it does. And this is the 6-week MRI, which looks good. So as expected, she's panhypopituitary on full replacement and DDADP. She didn't need any permanent CSF diversion. Her bitemporal hemianopia, which was evident when she was well enough to be assessed, actually took a little while to get better. So at 6 weeks, she still had a subtle bitemporal hemianopia, which is asymptomatic, but detected on testing. And really pleasing, she had no significant neurocognitive deficits.
I mean, that's a spectacular result, Simon, but why the proton?
Yeah, so the protons, if you look carefully on that sagittal, you can see just tucked behind the chiasm a little bit of enhancement at 6 weeks. But that on the 3-month MRI scan, that looked a little bit more prominent. So we discussed her at our panel, and the view was that this was only going to recur over time, and now was the chance. We had such a small target to treat. So if we're going to give her protons.
So there was change between the first scan and the early post-op scan. Okay.
Pretty subtle, but I think there was enough there to suggest that there was some residual disease.
Okay, well, Simon, that's a tremendous result, and especially with her neuropsych and endocrine status as good as they are, and vision as well, of course. So, Dr. Jane, please enlighten us. Agree, disagree? What would you have done?
So let me share my screen. Share. Do you all see my
Yes.
See the intro, and can you hear me okay?
Yes.
Great. First, thank you for asking me to participate in this talk and session. This is a extremely well done case. I am asked to comment on any opinions that I have about the case and ways that I would do it differently. I would not do anything differently, except the one thing in terms of the workup, I think it would have been worthwhile to get a CT scan. I like CTs. I generally will do a CT angiogram pre-op and use that in image guidance during the case. But having an idea of how much calcium am I about to run into, just so that you know, can be helpful. Now, on this CT, it didn't look like there were any big hunks of calcium that would have really been problematic. And indeed, you didn't find any large areas that would have been difficult. But I do think CT scan still plays a role. I use it primarily to map out the carotids during the case. I think that it is important to note that diabetes insipidus was unmasked by the replacement of the adrenal insufficiency. That's very common to see. So adrenal insufficiency will suppress diabetes insipidus, and it's not until you replace with hydrocortisone or replace with some kind of steroids that the diabetes insipidus is unmasked. I think it's also important to note that the tumor itself created the surgical corridor, as you've discussed. This was a great approach to go endonasally. Of course, if you knew that you were going to get all of that way into the third ventricle, into that monocystic portion that was in the ventricle, then you may not have gone from above to begin with if you knew you were going to be able to decompress the foramen of Monroe. But you didn't know that you were going to be able to do that. And I think, therefore, going from above, doing a simple septostomy and decompression of the cyst was a great idea. And then these are the results, and that's a terrific result. After a two-stage procedure, I think the question, of course, is, all right, what of this is residual tumor, and could more have been done? And it's a judgment call in the operating room. And your judgment was to stop at that point. And I'll show you a case where I did the exact same thing. And I don't think you can be faulted for having stopped at that point after you had accomplished what were the surgical goals, at least from below, which was to decompress the optic chiasm. So I will talk briefly about craniopharyngiomas in general. Jim Rucka, a number of years ago, said this famous quote in the Journal of Neurosurgery, that recognizing that craniopharyngiomas create a tremendous amount of controversy amongst practitioners, and there are a number of reasons for it. There are camps that believe in a gross total resection every time, others who feel that subtotal resection with or without some form of radiation post-op is the way to go. There are folks who are more heavily biased towards endonasal and others who are more heavily biased towards craniotomy. And we've mentioned the other less commonly used treatment options. Well, so there are a lot of different options. And why is that? And part of the reason is that these are highly variable tumors, so that one craniopharyngioma is not the same as another. And they can be, as in this bottom right screen, enormous, go retroclival into the third ventricle, be very challenging. They can have areas of calcification that creates a rim all the way across the top, an eggshell that prevents descending. They can be primarily cystic, and they can be easy like this one, right? So lots of different types of craniopharyngiomas lend themselves to multiple different ways that they can be approached, and one single way will not work for all. Craniotomies obviously play a significant role for many craniopharyngiomas, particularly ones that are lateral like this one. This would be a tremendous challenge to take out from below. And then there are some craniopharyngiomas like this one for which there are no great answers. So I believe that Simon, I used your picture, Simon, because it's so perfect to describe this, but this is you've shown perfectly the rationale for a transfemoidal approach. If for a midline tumor, this is a midline approach, you avoid any brain retraction and go straight to the tumor. And in this case, the tumor has created the interval. So I just want to make one basic point, because there are a million things that we could talk about with craniopharyngiomas. It's a huge topic for such an uncommon tumor. The one point I would make is to distinguish two basic kinds of craniopharyngiomas. Two. One that takes origin below the diaphragm, the others that take origin above. Now, the ones that take origin above the diaphragm, there are several kinds. They can be in front of the pituitary stalk, involve the pituitary stalk, be retro. They can be in the third ventricle. Yes, they are different. But for me, the distinction between whether it took origin below the diaphragm or did it take origin above has its greatest implications in the pediatric population, and I'll talk about why. So this tumor here obviously took origin above the diaphragm. You see a separate pituitary gland. Here, this tumor took origin below the diaphragm. You cannot see a separate pituitary, and the sella itself is expanded. So look for a sella that is expanded and the absence of a pituitary that's visible, and that will give you a very good idea that it was a subdiaphragmatic origin to the tumor, and that the third ventricle is likely not invaded, because if it took origin below the diaphragm, there often is a peel cuff that prevents the brain invasion that you so often see into the hypothalamus, which we believe is the cause for hypothalamic injury, hypothalamic obesity, cognitive deficits, and real problems. So I am much more likely to be aggressive surgically in a child who has a tumor that took origin below the diaphragm than a suprasellar craniopharyngioma. There are exceptions. So here is on the bottom right, a patient who has a multicystic craniopharyngioma. This tumor took origin above the diaphragm, but it did expand the sella, just like in Simon's case. And you can see this, the separate pituitary, you know that that is sitting below the tumor. This is a supradiaphragmatic origin tumor, and some subdiaphragmatic tumors do not expand the sella very much. So here's just an example of a patient with a subdiaphragmatic origin to their tumor. You can see left optic nerve, there's the ACOM, just peeling it away. There was a moment where I used sharp dissection, so I figured I should put that on a video. That's a joke. But peeling it away from the optic chiasm, liliquist intact posteriorly. Eventually, here's again left optic nerve, and trying to get this adherent tumor off. But you can see here's the floor of the third ventricle, and it is intact. That's actually lamina terminalis there. So here's the pituitary stalk in the end cut. One may have thought that this was a tumor that would invade the third ventricle, but now you know, no, the subdiaphragmatic tumors don't. So this child had a much lower chance of hypothalamic injury, and therefore in this case I would be much more likely to be aggressive during the surgery in terms of resection. This is just yet another case. This is an example of why it's nice to get a CT scan beforehand. You could have seen that there was calcification, but boy, I don't think you would have thought the calcifications were this much before the case. And knowing that you're going to run into that, I think is helpful. But again, this is a tumor that has a subdiaphragmatic origin, goes up towards the third ventricle, and in the end of the case, mammillary body, floor of the third, pituitary stalk, optic chiasm, but intact. Again, very low chance of having hypothalamic injury. This is a child who had multiple craniotomies, kept recurring from the sella, and again, another example where the third ventricular floor is pristine at the end of the operation and a much lower chance for hypothalamic obesity. So what about if the sella is not expanded? Or, in other words, the tumor has taken a origin above the diaphragm? Well, in that circumstance, I'm much more likely to take the tuberculum and planum. I agree with Simon that in his case, taking the planum would have been unnecessary. This is an example of doing just that and removing. My computer doesn't want to play it. It's embarrassing. The one shot I show, you see that I've inadvertently bipolared the superior hypophyseal artery. I didn't mean to do that, but there is nothing running through it. I had bipolared, but I had it up too high, and it went across. Well, ooh, that is. It's not a black screen of death, so. So I think we're going to be okay. It'll take me a sec, but not long.
Well, while we wait, let me ask you both of the question. You both chose to do a staged approach on this. How much time would you wait between the stages?
Well, I'll show a case in a moment where I just did it on the same day. Okay. But I think if somebody is pressure sick, get them not pressure sick, meaning fix the hydrocephalus, let them cool down, then do their, I think the way Simon did it was perfect.
Simon, how long did you wait?
I think it was a couple of days.
Couple of days, okay.
It wasn't very long, yeah. The first case was done out of hours, needed a bit of endocrine input over the next couple of days. And I think once we'd got the endocrine issues addressed and the patient had normal electrolytes, then we just pressed on at the first available opportunity.
Okay, John, please continue.
So there are times where I will preserve the pituitary stalk. This is an example of preserving the pituitary stalk. Not a huge interval between the chiasm and the top of the gland. Here you can see is the pituitary stalk. eventually get into this primarily cystic tumor. And so I'm more willing to accept small corridors if I'm dealing with a primarily cystic lesion. And eventually get into it. But it's clear, and I'll show you where, it's clear that although I decompress the optic chiasm and start peeling this away, as I get a significant amount of the wall out, there is that portion at the end that is just this wispy amount, just this wisp. And Simon's case had this exact picture. I remember my father was in the room and telling me, you should take that out. I started and I immediately started bleeding. And I said, Pop, I don't think I'm going to take that out. I left the pituitary stalk intact, and the patient refused further treatment. And she's done well for, well, as of 8 years post-op, no radiation. And for whatever reason, that film doesn't enhance and has not been a source for recurrence. She did not have DI. Last case is this one. This is that case where it has a super diaphragmatic origin, multicystic. There is a hydrocephalus. A neurosurgeon at an outside hospital had placed an Omaya, which didn't work. Simon's already shown this, doing a septostomy, going in, there's the cystic portion. I think with the NICO, perhaps you could take more out. And we just had a recent case with Dr. Syed where he used the NICO more. Then going in to take this tumor out. You've already seen a beautiful video by Simon, no reason to show mine. I did choose to leave residual again because this was a child. It was invasive of the third ventricle, and I left that residual right here. The family has refused radiation, and it's been years without progression. This was our more recent case where there was a very small window between the tumor and the cystic portion. So Dr. Syed went in through the ventricle, did a septostomy, popped this cyst, and then we went from below. This was an older patient, but for whom I wanted to be more aggressive, but I left this residual tumor under the chiasm because I could not get it off. So I would have preferred a complete resection, but just could not get it. So again, I would ask you all to try to distinguish subdiaphragmatic origin from origin above. If it's subdiaphragmatic, then it's less likely to invade the hypothalamus, and at least in pediatric patients, you can be more aggressive with less of a chance of injuring the hypothalamus. That's it.
So thank you. There was one question from the audience, actually from our own production assistant, that asked whether any of you would do these two combined above and below procedures simultaneously. I think that was in vogue for a little while, a little ways back, but I think fewer and fewer people are doing that for various reasons. And John, I love your point about letting them get hydrocephalus well before attacking anything further. And also endocrinologically, they can get better before you attack the tumor from below. So is there a moment where you would do a simultaneous above and below procedure?
Well, both of the cases I showed we did on the same day.
Same day, but not simultaneous.
No, yeah, didn't do it simultaneous just because too much of an engineering pain.
Mr. Cudlip.
I can't see any huge advantages over doing it simultaneously.
Okay.
Other than convenience. And as John says, it's logistically it'd be difficult, I think, because it's a whole new position, and yeah, I can't see a huge advantage in doing it.
We have to wrap soon, so I'll say this, as I view myself almost like a TV producer, and this episode has gone on absolutely perfectly. The presentations are beautiful, the videos are beautiful. I only have one worry, and that is that it's really boring TV when everybody agrees. So you both agreed, and so much so that I actually have to throw in a monkey wrench. I think that I really like Jeff's idea about going transcallosal. I think if this came to my attention, and granted, I only do adults now, the EVD would have gone in, get the hydrocephalus solved right away. And I would probably have done the transcallosal approach and decompress the cyst, open the septum pellucidum. And you guys remember that movie, The Mask, the Jim Carrey movie, at the very end line, "Somebody stop me." I would have very difficult time holding myself back after I decompress the cyst to not go after the solid component deeper and deeper and deeper, going transchoroidal. And I think that, it's obviously it's highly dependent on your own experiences and whatnot. And I just simply don't have you guys' experience dealing with craniopharyngiomas from below using that infrachiasmatic interval. So I probably would have gone almost all the way, maybe even getting a reasonable resection from simply a transchoroidal one stage. And then, you avoid two anesthesias. A lot of people say that there might be some advantage to that. Hassan, any major questions from the audience that we need to address?
I think there were a couple questions. One about doing a CT scan. I think Dr. Jain mentioned, sort of for pre-op planning and see the calcifications. He answered that. The other question came up regarding pituitary transposition and craniopharyngioma surgeries, and experience with that, and when to do that. If there's anyone who wants to answer that.
I can't see a role for it. The origin of craniopharyngiomas is usually anterior and superior to the pituitary. So transposition's been described typically in cases of chordoma or tumors arising behind the pituitary gland and infundibulum. And again, the Pittsburgh guys use it quite a lot, and I've seen some nice studies. How often they preserve function is debatable. So anatomy is nicely preserved, but function is a bit more variable. But I can't see a role for it in craniopharyngioma. I don't know whether John Jones Jr. has a view on that.
I do. The fact is that new pituitary deficits are very common in my hands post-op. And particularly in the subdiaphragmatic tumors are present at presentation, and a maneuver to preserve the pituitary anatomically typically is not indicated when the real question is, do I cut the stalk or not? It doesn't matter if you've transposed the pituitary if you in the end cut the pituitary stalk. So yeah, I don't think it plays a major role.
And a couple of questions regarding identifying the hypothalamus and how to deal with tumor attached to this. And I know that Dr. Cudlip mentioned as well, sometimes it's difficult to tell the transition and the gliosis. Any comments on that?
Well, I think the advantage of the endonasal approach, this particular part of the operation, is you can do this under direct vision. So the difficulty with all of the craniotomy approaches is it's a semi-blind procedure. When you get to the stage of dissecting tumor from hypothalamus, you do not get a clear view. And the endonasal approach does have that advantage, but you saw in my case, sometimes the distinction between craniopharyngioma, gliotic brain, normal hypothalamus is difficult. And so therefore you have to make a judgment call during the surgery. And hopefully you've counseled the patient about, so I set, the goalposts are set before the operation. I ask the patient, how far do you want me to go? If I can achieve a GTR, then great. But if I can't, are you willing to incur any you know, endocrinopathy, excess morbidity. And a lot of people say, no, I'd rather you left some and then we irradiate it. I think they're right.
It is 7 o'clock, and so we have to close so that we can go to the operating theater. Thank you, everybody, for your hard work on this. This has gone absolutely beautifully. Your videos are spectacular, and your skills are even more impressive than that. I just want to make a plug for next time. We are going to be back in 2 weeks live, this time, once again, with an international panel, one from Hanoi and the other one from Paris. So it is, again, really early for the United States. It's 6:30 in the morning because of Parisian and Hanoian time, and we will see you back there. This episode will be on our YouTube channel, hopefully within the day, and as it is time to say goodbye, thank you for our audience for being with us. Thank you for your valuable questions. Mr. Cudlip, thank you for your work, and Dr. Jane as well. And we will see you all very soon. Thank you, Jeff, as well, for being in hot seat. I hope you enjoyed it.
Yep.
Okay, ciao, everybody.
Take care.
See you.
Thanks for inviting me.